Hello, and thank you so much for joining us today for the webinar Interactive Diagnostics on the Basis of CBCT Images Part 2. We would like to thank Dr. Joerg Mudrak for being with us today and our sponsor for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by the doctor at the end of the presentation. Without any further delay, please help me welcome the expert himself, Joerg Mudrak.
So, dear colleagues, ladies and gentlemen, welcome back, or hello from my side. Thank you for joining this second interactive webinar, and we will directly start into this webinar by showing a brief introduction of what diagnostics alternatives we have in our day-to-day business in analyzing patient data. First of all, of course, we have the intraoral imaging computed tomography, which is more or less the additional method to have or gain more information. We have our standard extraoral imaging. Now more and more getting popular, the magnetic resonance imaging, and of course the not new, but relatively new technique of cone beam computed tomography. Ultrasound is getting more and more common just in analyzing soft tissue, especially glands. In our department, maybe the bone scintigraphy is not the first choice, modality of choice, and as addition to complete this list, we have the PET imaging modality, which is another option in analyzing data. All right, so let's check what has changed over the years. When we look back to the year 2002, 2004, remember in 2000, the first cone beam had been used in medicine or in dental medicine. There you see a brief table of what the main indications had been. There had been a limited amount of indications, so it was a relatively new technique. Most of the colleagues had been still relying on the old-fashioned way, on the conservative way, like extra and intraoral 2D imaging. And if we now check the indications of 2012 to 2014, where we did this evaluation, you can see that there is basically still the same indications we had 10 years ago, but they are more. That means the technique is getting more and more popular. You see more and more indications to use this, and that's why we need now, of course, the adoption of our ability to analyze data. There are a lot of cone beam units on the market. Weekly there are launched new units, and the image quality is basically not bad in all. There are some pros and some cons. You have to evaluate for your own praxis, for your own clinic, what kind of unit you prefer, if it's only strictly 3D or it's a combination system like you see here in these images, or if it's strict 2D. The dose, I think, is not that big issue anymore, as the cone beam computed tomography is already a low dose technique. But now there are some units on the market which show another dose reduction, and that means that we are able now to achieve an image where we spend dose between 7 and 28 microsievert. This brings us into a little bit a messy situation, because we have now to evaluate if we take an extraoral digital panorama image, which has a higher dose than a small field of view or a middle field of view cone beam scan. So this is what we have to see in the future, what surplus this dose reduction technology will show us. If we look at the workflow, of course, we have to take the images. That means we are taking many hundreds of projection images that goes in one circle around the patient. Then after this, we have to do some reconstruction. That is not what we do. That is what our computer is doing. So that means we need to have the hardware which is able to reconstruct the huge amount of data we are achieving. And of course, the most important part then afterwards is to choose the right platform or the right software to edit the images. That means we are now in the status where we have to visualize, to show the boxes as images. There are, as I mentioned, a lot of software programs on the market. I'm dealing mostly with the on-demand 3D software from Cybermed Korea. And there we have one modality which I will use today mostly. This is called multiplanary format. That means we have a calculation by the firmware, by the software of an axial, a sagittal, and a coronal slide. And in the third or fourth window, we have then always a surface rendered view of the data. Image editing. So what does that mean, at least? If you are in your own clinic, you will have the anamnesis of the patient, the medical history. But if you are a referrer clinic, it might be that there is some lack of information. That means we have in the most cases, a limited knowledge of the medical history. If you are just focusing on image editing, you are not able to perform any kind of clinical examination. And you have, in the most cases, referring to the globalization in the world, which is happening every day, we have limited general information about the patient, about the background. On the other hand, we need, of course, help. It's nothing in the world we can do on our own. That means we need interdisciplinary skills. It is a kind of teamwork. And in a lot of cases, we need the results of the histopathological examinations. So what is the backlog? That is, I think, concerns any one of us. First of all, the lack of experience, the way back knowledge. I remember we have some cases that you maybe have heard of last time when you had been at university, and the rare incidents. That those cases do not pop up every day does not mean that they are not existing. And as I mentioned already, the globalization brings as much positive as much negative. So that means we have patients from different countries where we have no idea where they are coming from, what their background is, and what kind of diseases they might have just in referring to the images we take. So then let's sum up this together. That means if we are facing the challenges, first of all, the know-how, then to have a kind of education in how to do a slice imaging. The 3D imagination, that means we have to be aware of the fact that we have to combine 4 different views in the end of the day to one image and then take our conclusions from that. We have to be careful in transferring antiquated knowledge, and we have to be careful that the projection radiographs do correlate with the 3D information. And in the last step, just one example to this. You see in this image an axial view of a non-ontogenic benign tumor of the connective tissue. It's called granuloma gigantocellulare. And on the other hand, you see a patient motion artifact. And this patient moved the head rotating to the right and tilting to the left. So if you have not the needed experience to analyze those images, it might be the case that you mix up the diagnosis. When I show you this, that you mix up the diagnosis in this area with this area. The opacity or the lucency does not give you any information if this is a motion artifact, for example, or just some kind of tumor. So, what is now our job for today? We will have different gradings. We will have a grading. That means we will look at the absorption. That is what we always do. We look at the form, at the neighboring structures, the localization, the structure, and the borders. And when we have all this information together, then we might or will drop in one of those radiologic boxes, as we have the development, trauma, inflammation, or tumor. And this is now the first case. A brief description. It is a 23-year-old female, expansive mass in the molar region of the right mandible. Swelling was hard, painless to palpation, and covered by normal mucosa. Teeth pain and paresthesia on the affected area. No extraoral swelling. So that means we can now focus the location. In this case, it's the mandible. This is now the coronal view, the sagittal view, the axial view, and the rendered view. If you like, just grab a pen and a piece of paper so that you can do some remarks, some marks, and then we will proceed in analyzing this case. All right, so let's take a look. First of all, we have the absorption. So if we look at this case, we have the soft tissue, we have the air, we have the bone, we have the two structures. Here we have the running of the inferior mandibular canal with a calcification line on the bottom and on the top. And this is now our main focus of interest. This is the axial view. So we can make some notes. For example, it's a hypodense structure in that area. The next would be then the form. So here you can be really, play with your fantasy. You can name it as you like. You can, for round, elliptical, banana shaped, apple shaped, pea shaped, whatever you have that you think that other people can understand what your meaning is. And of course, we can write the extension. That means in this case, it's from the first premolar up to the first molar. In the next, we have the structure, so we can give or gain some information. Is it homogeneous or inhomogeneous? I think you agree that in this case, it looks like a homogeneous structure inside that finding. But it can also be septate or saucer-type-like or locular. In the next step, we will then look at the borders. And this is very, very important, especially when you do the editing of tumor cases, because if you have no sharp or regular borders, then it means that you can have somehow a integration of this defect into the bone structures, and this might have an impact on the outcome of the treatment. In the next step, then we look at the neighboring structures. Are they infiltrated, destructed, displaced, wedged out, or embedded? In this case, we could say that it is somehow displacing at least the roots of the premolar, but it does not really look like as if it were destructive. Of course, inside that area, there is no bone left. Okay, so if we sum this up in referring to our table, then we could state that we have a kind of lucent absorption. I called it pear-shaped, but this is just an example. The neighboring structures are somehow displaced. The localization is to 4,4 to 4,6 or US 1,9,2,2,1. The structure is homogeneous. The borders are more or less regular or sharp. And I gave you already some little hint. We will end up in this box. And now I would like to mention the differential diagnosis for this first case. First of all, there we have to take into consideration the keratocystic ontogenic tumor that you see in this area. Then we might talk about the odontogenic myxoma you can see in this area. This is, for example, some description like lobular inside this finding. The next might be a dentigerous cyst or a follicular cyst, which you can see here and here. And the last we have to discuss is then the Unicyclic Amiloblastoma, which you can see here in this region. Okay, I think now it's time that you start. You get approximately 1 minute, 60 seconds to make your choice, what in your opinion the main diagnosis might be. I'm not talking about the lucky findings. And so I'm very curious to see what your opinion about this case is. And the variety of your ideas. So you still have 30 seconds left, so take your time. There is not that much hurry. Remember all the single facts that we have listed, so that means we have a kind of table which does hint to some kind of diagnosis, and I see the variety is very large. That is very good. So it means you are really thinking about that. Very good. So you still have now you have still 10, 9, 8, 7, 6, 5, 3, 2, 1. Second, okay, let's close now. This is a very interesting result. And now let's see what the diagnosis of this case has been. And you see, this had been a Unicyclic Amiloblastoma. This was histological proof. And this Amiloblastoma is the second most common odontogenic benign tumor. Benign is always relative, and account for up to 1/3 of those such cases. The appearance can be either totally radiolution, unicystic, or radiolution with internal septa like soap bubbles, multicystic. And then the differential diagnosis to the ontogenic myxoma could be very, very hard. So that means here we need then a little bit more background about the patient, about the medical history, etc. So very well done. But you see, it is not that easy. It's not a self-running thing. We have to take a lot of things into consideration. All right, very good. Here's some information about the differential diagnosis. First of all, the odontogenic myxoma. Then we talk about the keratocystic ontogenic tumors. The keratocystic odontogenic tumors are very, very hard to treat because you have a lot of rebounds. It is very hard to remove the whole, in parentheses, tumor. And it's if you don't get it at all, it will always come back. So it's not an easy thing to treat, and it's not very convenient for the patient. And then the dentigerous cyst or follicular cyst, we all know this, they are slowly growing. Benign, non-inflammatory, second most cysts that are thought to be development in origin. But the radiographic appearance, this is the most important thing, is well-defined unilocular radiolucency surrounding the crown of an unerupted or impacted tooth. This is the most important sign for a so-called follicular cyst. All right, so let's look for the second case. We have, once again, to remind you, we have this kind of features that we are looking at. And now let's see what we have to describe. So the second case is a 77-year-old male patient. He was referred for basically implant cleaning. There had been no severe medical or dental anamnesis or general anamnesis, so that was completely bland. And we are now, first of all, checking again the localization. This is the coronal, the sagittal, and the axial view. Then you see the rendered view. So this is the mandible, we can agree, and it is the ramus in this case. And now let's go a little bit more to the detail. First of all, the absorption or density. I think you agree that it is a hypodense finding that we have. It is a calcification line around. So the next is that we look about the shape. So you can call it heart-shaped or pear-shaped, just as you like. Just always choose some description where anybody can follow. Then the structure, is it homogeneous or inhomogeneous, lucent or not? Is it septate? I think we agree that there is more or less a homogeneous structure. and the borders. The borders are, in my opinion, quite sharp and regular. So there is nothing that is irregular in this area. It's well defined, more or less. It's all relative. And the adjacencies or the neighboring structures, I think you agree that we can name it destructive, because there is some mass missing over here. It looks a little bit, in parentheses, like a hole. So there is some destructive issues going on. And this is now what we have to decide. I intentionally did not drop one of those boxes down here because it's not very easy to make a defined categorization. But we sum it up, it's lucent, it's pear-shaped, destructive, it's in the mandible, in the ramus, the structure is more or less homogeneous, and the borders are regular and sharp. Okay, then let's take a look at the differential diagnosis. First of all, lucent lesions of the mandible are not uncommon and may be the result of ontogenic or non-ontogenic processes. So one of those processes is, for example, the fibrous dysplasia or cherubism. This we had in the first part. If you joined, you might remember this case. Then the second we have to discuss about is also non-ontogenic mandibular metastasis. I will come back to this later. The third, non-ontogenic staph cyst, and the fourth, ontogenic periapical radicular cyst, which are around about 60% of all ontogenic cystic lesions. So now you got another 60 seconds to make your decision of the diagnosis, and maybe you maybe you also think about the radiologic box we were dropping in, because in this case it's not that easy. So I can see that there is a quite unique opinion. Now it's getting a little bit more variations. So all differential diagnoses are not just originating from my fantasy. They are really related to the case, and it might be anything of that. Please keep that in mind. Okay, so we've got another 15 seconds. Okay. Maybe one hint in the last 5 seconds, the localization is a little bit atypical for that finding. So we have now 10, 9, 8, 7, 6, 3, 2, 1. Okay, so let's see what we are talking about. We have 3 main indications, and we talk about the non-ontogenic staph cysts. They are basically cortical defects near the angle. This is why I mentioned it's a little bit odd localization. And they are below the mandibular canal, not a cyst, because it does not contain any kind of fluid. It is mostly an incidental finding. It could be representing the depression of the medial aspect of the mandible filled by part of the submandibular gland or adjacent fat. But this is not the case here. So the origin of this finding is not really clear, but it is a kind of staph cyst that had been proven. All right, so very well done. Now, let's take a look, as I mentioned, the lucency at the differential diagnosis. So we have the fibrous dysplasia again, and some metastatic lesions. This is very important. They may occur in the oral soft tissues, in the jawbones, in both osseous and soft tissues. It's very important to know. We will see that later on. So now we are busy, and we are now looking at the case number 3. First of all, again, our grading. So we have our boxes and we have our single issues, single files. So this is now the next case. It's a 45-year-old male patient. He was originally referred for paranasal sinus imaging. He had non-specific complaints, and there had been no hints in any for any kind of medical anamnesis. But as we can see, there is something that is located inside the sinus. And first of all, we have then again to check, okay, where are we? So from the anatomy, we are now in the ethmoidal sinuses. That means maxilla, skull base, ethmoidal sinus, and this is what we are talking about. So in the next step, we talk about the absorption and density. So it's always the same scheme, and I think you agree that it is more or less hyperdense when we look at this structure. The form, okay, it's a little bit difficult. It could be roof-shaped or pea-shaped. This is something that you have really to think about in your fantasy. I described it as roof-shaped. And then the next step is the structure. It is both. If you look at the detail, you see homogeneous and inhomogeneous areas inside this finding. The borders are quite sharp or regular, so it's well defined. There is no destruction anywhere. And the neighboring structures, I think it's more or less embedded. It's not somehow infiltrating or destructing any kind of anatomical structures. All right, so this is what we sum up together. We have a hyperdense, hypotensed absorption. The borders are regular or sharp. It's an inhomogeneous structure. I named it roof shape, but it's up to you to call it differently than the neighboring structures. It's embedded. It's in the skull base, in the ethmoidal sinus, and some hint it's a kind of tumor. What differential diagnosis we do have in this case? First of all, the osteosarcoma. Then we have the fibrous dysplasia. The Cemento-Ossifying Fibroma. This is a large finding. And the osteoma, as you can see here in this area. Okay, now it's again up to you. You got another 60 seconds to make your decision about this case. Remember the location and especially the inner structures of this finding. So in the moment, it's a quite unique decision. Yes, okay. You have still time, so take your time, take into consideration what we have collected, what kind of information we had. Think about the age of the patient. Okay. So you have decided between the osteosarcoma and the osteoma. So then we have another 10 seconds now. Okay, 3, 2, 1. Okay, then we close this poll. Yes, you have made some quite unique decision. So let's see what what we are talking about in this case, and 60% of you have been completely right, but the other 14, it's not that far away. The osteoma is a tumor which occurs a lot, quite frequently in the paranasal sinuses. It is usually found incidentally, like in this case, mostly when people undergo imaging of the sinuses, and it can appear up to 15% in the ethmoid air cells. So this is something, the high number I didn't have in my mind when preparing this, but I knew that it can appear in this area, but up to 15% is a lot. So well done. I see you have a lot of experience in reading and editing images. Let's take a brief look at the differential diagnosis, the fibrous dysplasia, which is very, very often named as a differential diagnosis. The osteosarcomas, they are really malignant bone-forming tumors, and that's why 40% of you are not that far away. The second most common primary bone tumor after the multiple myeloma, and they account for up to 20% of all primary bone tumors. And there are different forms, primary and secondary. There is a lot of more information, of course, that you could gain about this kind of disease, but I did not list all at the end of the day. But of course, if you like, I can send you much more information about this. And then the last had been the Cemento-Ossifying Fibroma. It's quite rare. It's also a benign neoplasm, and it usually arises from the mandible or maxilla and from the tooth-bearing areas. This is important to know. And in the ethmoidal cells, we do not have any kind of teeth. All right. So now let's go to something a little bit more special. This is now the case number 4. Again, our scheme. And now some information. And this is what we have quite often. We don't know about the age. We see from the clinical point of view that it is a female patient. We have no idea about the dental and medical anamnesis. And we see obviously that there is some kind of retained, displaced, or supranumerous tooth in the maxilla. But this is not the main indication. This is a side finding. So what we are talking about is in the maxilla. It's in the tooth-bearing area. And now we look at the teeth of this patient. Just look at the structure and the appearance of the teeth. So then we go to our little description. That means, first of all, we describe the absorption and density. So just focusing on the teeth, we could say, okay, it's like bone, tooth, and soft tissue-like. It's hypodense and hyperdense structures. The form you can name as you like, H-formed or not really describable, like a trapeze or whatever, in this round-shaped. I'm talking about this area here, or this area, or especially this area. We have the structure, which is, in my opinion, quite homogeneous. We talk about the borders. So we are now really talking about a single teeth. So we have now to make our decision. What is smooth? What is sharp? What is blurred? What is irregular? Is it homogeneous? Inhomogeneous? Is it well-defined borders? Are there well-defined borders or not? And then we look at the neighboring structures. Neighboring structures in this case would be the dentine, for example. Is it destructive, displacing? If we just focus on the tooth, it's destructive. And then we have to do our summary. So if we talk about hypodense structures, an undefined form, or mention H-formed or however you name it, it's embedded. It's in the maxilla. It's a homogeneous structure, and the borders are regular and sharp. So this is what we have as information. A little hint is the box development. Otherwise, it would be too hard for you to make the diagnosis. But let's take a look at the differential diagnosis. So first of all, we have the ectodermal dysplasia. Second, we have root resorption. We have the internal granuloma, and we have taurodontism. So now it's up to you to make your decision about this case. We have the most obvious differential diagnosis, which are related to our department. And now you have around about 1 minute to make your decision. As I mentioned before, in this case, anything is referred to teeth. So when we talk about adjacent structures or neighboring structures, we talk about dentine, not bone. If we talk about lucency, we talk about the KaVo and not about a bone defect. Okay. You have still another 10 seconds left now. Yes, I see you focused on one special kind of disease or syndrome. All right. Okay, so we close the poll. And now let's see what this diagnosis had been at the end of the day. You had not been wrong. In this case, it's taurodontism. It's a condition found more or less in the molar teeth, whereby the body of the tooth and pulp chamber is enlarged vertically at the expense of the roots. That's why it's sometimes not easy to make a differentiation between the internal granuloma and a root resorption, for example. So let's take a look at some differential diagnosis. The ectodermal dysplasias are described as heritable conditions in which there are abnormalities of 2 or more ectodermal structures, such as the hair, teeth, nails, sweat glands, salivary glands, craniofacial structures, digits, and other parts of the body. So one incidence alone is not enough to make the diagnosis ectodermal dysplasias. You need to have at least 2 of those mentioned abnormalities. Root resorption as breakdown, destruction, and eventual loss of the tooth root structures. There you have a really destructive way or a destructive visualization. The same you have in the internal granuloma. It's a chronic inflammatory tissue type, resorbing the tooth from inside without causing pain. We didn't have any kind of resorption. We had regular tooth structures. But this taurodontism is associated and related to many more diseases. I would just name some of this. First of all, amelogenesis imperfecta. Then we have the trichodento-osseous syndrome, where you have also this kind of multiple abnormalities, meaning hair, teeth, and bones. It's rare and systemic. It's a genetic disorder. And it is somehow related with taurodontism. Then we have the Klinefelter syndrome, which is the triple or double X syndrome. It's a set of symptoms that result from 2 or more X chromosomes in males. This can also be associated to taurodontism. And we have the so-called pentasomy X, penta-X or 5X syndrome. This is extremely rare. It's a chromosomal aneuploidy where females have 5 X chromosomes rather than the normal 2. So you see there is much more which can be related to one more or less, in parentheses, simple diagnosis. So we have always to look a little bit further than just in that focusing on just one region or on just one analysis. And the last one is the so-called tooth and nail syndrome. And as you can see, there is a special relation from Taurodontism to those ectodermal diseases, which you can see here. It's very rare, and it's Witkopf syndrome. Maybe you have heard about this. It's a rare disorder, and again characterized by nails that are thin, small, and friable. All right, so far we will now go a little bit further. And the next case, I would like to ask you just sit back and relax and take a look at this case, because it shows the complexity, the challenges, and the variations that we have to face in our day-to-day image editing. This is a case, here again our boxes, I think you know them already now. This is a case of a 55-year-old male. He got a 1-year history of neck pain, headache, and hearing loss. And as you can see from the clinical view, he got a short web neck, a decreased range of motion in the cervical spine and the low hairline. This is what you can see here. So this is what the clinical examination showed. He has lost the symmetrical expression of the face, and his maximum mouth opening is restricted to 30 millimeters. So you see the lateral, the distal, and the facial view. Another description of the cervical X-ray showed that there is a posterior partial fusion of C2, C3, 4, and 5. There is a hypertrophy of the posterior vertebral elements at levels C5 to C7. So if we talk about location, then we have, first of all, now here, the cervical spine. This is one issue. If we now go to our department, then we take an intraoral look. First of all, you see the narrowing of the airway space. You see a severe periodontitis, a high arched palate, a maxillary sinusitis. This patient suffered under an early tooth loss. He suffers also under sleep apnea, which could be related to that restricted area of the airways. So this is what the information that we have for our department. Nevertheless, you can see from this lateral view that we have always, or quite often, some parts of the cervical spine in our images. Only depends on how we position the patient. So if we now refer to our department, to our convenience zone, then we have to discuss about what we can see from the absorption. So we see that there are some hyperdense and hypodense structures. If you look at this one, you see the horizontal bone loss. You see radices relictus in the maxilla. Sorry. You see the left maxillary sinus, and you see the narrowing of the airway space as well as the high arched palatal arc. So then the form, this is very hard to describe because we have somehow a vertical tooth loss, a vertical bone loss. On the same time, we have some lucent area in the apical region of this canine. We have some bone loss in the horizontal, in the maxilla. Then we have this structure in the sinus. As I mentioned already, we have homogeneous and inhomogeneous structures and borders. The borders, of course, if you have destructive elements, you will have a sharp border somewhere. You still can see that. But you have also some irregular borders which are not really sharp when there is still the alveol to see where the tooth had been lost from periodontal disease, for example. The adjacencies, of course, they are destructive. Bone loss is always destructive. It is not displacing. You have also destructive parts in this area. And this is now our summary. Of course, you could give more details already over here, but at least some hint to give you is the development and inflammation. This is more our convenience zone. This is what the general disease is all about. So there is no poll this time. With this case, I just wanted to show you how complex the examination and the image editing can be. And I will now give you the solution, or for this case, it's the so-called Klippel-Feil syndrome. It's a very rare disease, and it's characterized by the congenital fusion of any two of the seven cervical vertebrae. It is associated with abnormalities that might be scoliosis, spina bifida, anomalies of the kidneys and the ribs, and a cleft palate. Dental problems, late dentition, high risk of caries, oligo or hypodontia, respiratory problems, heart malformations, and a short stature. It's it's a female predilection. The incidence is 1 to 40,000 to 42,000. What my goal with this case was that we often have parts of the cervical spine in our images. If you look at this lateral view, you can see that you have the spine in this area. So, and we are responsible to analyze the whole data, not only that is what is in our convenience zone, anything. So we have to be aware of the fact how it is, what is how looking like. That's why I wanted to show this case, because if you look at this list, you find that primary tumors most frequently encountered as metastases to the skull. You have breast cancer, lung cancer, melanoma, prostate cancer, thyroid cancer, renal cell cancer, lymphoma, leukemia, and multiple myeloma. So those primary tumors do have metastasis in the skull or in the jaws. So as I would like to point out again, there are many more variations in the patients, of course. They are human beings. There is a lot of variation, but we have really to look at the whole image and not just focus on one area where we think that we are at home, which is our convenience zone. If we find something, we always have to look at the complete patient and not only focus on one single issue. All right, so all the work we have done, we have to do some kind of documentation. It's mandatory to do some documentation that can be custom made, or the software gives you the option to do this by the software, where is a program integrated, for example. The referrers, and this is quite important to mention, they need information. We need information. That means the patient has to get some documents where we exactly know what to do, what the main indication should be, what we should look at, the field of view, and all this kind of information to give at the end of the day a much better diagnosis and not unknown age, no medical anamnesis. Then it's more or less, it could be, could not be, not really a guessing, but it's very difficult to make the final decision. Conclusion. I think that we agree that the cone beam computed tomography is quite well suited for the imaging in the dental craniofacial head and neck area. I want to point out there is a lot of software on the market, and we need to find the one where the workflow is the most convenient for us. We need experience in image editing. It's the basic of all diagnostics. So putting this webinar together, I learned already again a lot. This is really an option where you are really, where you have to check the internet, check books, not to mix up diagnosis. We need adequate software programs that enables us to get the additional information. and the assumed anatomical pathologies. And of course, and that's why I thank you very much for your time to join this webinar, that the education and the knowledge must be improved. And with this image, I would like to say thank you again, or thank you this time. And we plan, if you like, to do a third part in autumn, showing some image editing software and focusing strictly on dental indications, little bit intra-alveolar findings, etc. Thank you very much again. I'm now here if there are some questions. Yes, you can find this first part in the DT Study Club website, and there you click on the archive, and there should be the video of this first part. DT Study Club. You just Google DT Study Club, and then you will be referred to the website, and there you can find webinar. And from the webinar, there is a kind of button or icon where you can click on archive, and then you can find it. I think it's also available on the KaVo website. No, you don't. No. That was not this webinar was made for. It's yes, of course, it's a little bit of hint to do something, but don't mind. So don't worry. Thank you also. Okay, I think if there are not more questions or critics or remarks, I think then we can close down the webinar.
We would like to thank our speaker for sharing his knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.